Today we will hear about Dopesick, Dealers, Doctors, and the Drug Company That Addicted America by Beth Macy. The New York Times describes Dopesick as, quote, a harrowing, deeply compassionate dispatch from the heart of a national emergency. And I'd like to read just a few sentences of an excerpt from the book. The 1996 introduction of OxyContin coincides with the moment in medical history when doctors, hospitals, and accreditation boards were adopting the notion of pain as the fifth vital sign, developing new standards for pain assessment and treatment that gave pain equal status with blood pressure, heart rate, respiratory rate, and temperature. The seismic shift toward thinking of patients as healthcare consumers was already underway, and doctors and hospitals alike competed to see who could engender the highest scores, incentivizing nurses and doctors to treat pain liberally or risk losing reimbursements. Our presenter today is Dr. Michael Mendoza, Commissioner of Public Health for Monroe County, and I ask you to please join me in welcoming him to our podium. Thank you.
Thank you. Thank you very much. Can you all hear me in the back? Okay, wonderful. All right. Well, thank you very much for that kind introduction. And thank you all for coming. My name is Mike Mendoza. I'm the Commissioner of Public Health for Monroe County. I'm a family physician by training. I also have a clinical practice. I'm still in practice at Highland Family Medicine, so I still see patients. But the vast majority of my time is as a Commissioner of Public Health for this county. I was pleased to get the invitation to review this book because it is a problem that you all know has struck our county in ways never seen before. The extent to which this crisis has impacted our families, our communities, our neighborhoods, our churches, our schools is completely unprecedented. And when I first read the intro to this book, I wasn't surprised. The stories that are told in this book are stories that I have heard here in Monroe County. I hear these stories from my colleagues in medicine, from families, from churches, from educators, and so I would actually encourage you to read this book. It shares a very different perspective on the crisis, one that is not typically covered in our typical news cycles. This book really digs in deep into the crisis, and it really gets at a lot of the complexity that I think is overlooked often when you're trying to describe a crisis of this magnitude in 3 or 4 minute sound bites or short news clips or even newspaper articles. So I want to thank you for coming today. I'm going to share a little bit about what I learned from this book and then provide for you some of the local history, some of the local response to this crisis, and we'll leave some time at the end for some questions. So the book is set in Western Virginia, not in West Virginia, but in Western Virginia, around Roanoke. Beth Macy is the author. She is a retired photojournalist, and I actually corresponded with her prior to this talk. Shared with her sort of what we were going to do today, and expressed to her that even though I had heard so many stories from family members in particular, the stories that she told in this book were particularly telling to me. She did a wonderful job, beautifully retelling the plight of a family in particular. Tess was her name, the daughter, and the mother's name was Patricia. That thread goes from the beginning of the book until the end, and I won't spoil it for you, but I would encourage you to read the book. But it did a very good job underscoring the humanness of this family. You know, if there was one thing I could change about this crisis, it would be that stigma that exists around addiction and around those who struggle through addiction. And this book does a very nice job breaking down that outer shell and really getting into the tenderness of what these families experience in their day-to-day life, the struggles that they go through, and the very fact that they're people just like you and I. This book underscored for me what I've known for some time, which is that this is a disease. This is a disease. Addiction is a disease of the brain. And I don't think as a profession or as a community we treat it yet in that way. Because I see a lot of judgment, a lot of blame, a lot of pointing fingers in multiple directions around this crisis. And the fact is, people who are struggling through this illness are struggling with a disease just like people who struggle with heart disease or cancer or diabetes. I mean, these are diseases that by and large are not of our choosing. And by the same token, we can't simply wake up one day and wish it wasn't there. And the same is true of addiction. And that is a reality that this book drove home very clearly for me. So it's set here in Western Virginia, beautiful area of the country. I don't know if you've ever had a chance to drive through there, but I've gone through many times. A beautiful part of the country. And the reality is that this book could have taken place here. This book could have taken place anywhere in this country. The fact that you've got a beautiful landscape like this is not in any way protective against an epidemic of this magnitude. Because anywhere you go, there are people who are struggling through poverty, through injustice, through racism. And it's true in Western Virginia, it's true here, it's true across the country. Now, the extent to which this crisis is impacting different communities is different. But I would say that the primary themes that you hear of in Western Virginia would very easily apply to upstate New York. And so this is a picture of a typical West Virginia town. You kind of see this sort of dual-sided, bucolic kind of environment where you see, you know, all this natural beauty juxtaposed with a lot of very human, real suffering. And the sad reality is that this is a crisis that's affecting every part of the country, every state, in unprecedented ways. What I'm showing to you here is the United States colored by state with regard to the age-adjusted drug overdose death rate. The dark blue there is states where the average is higher than the national average. Green is below the national average, and blue is basically at the national average. And you can see here that the Northeast, ironically sparing New York State, is very hard hit by this crisis. And there are a whole lot of studies into why we think that is, and the fact of the matter is that we don't really know. But the fact is it's really impacting the Northeast much more than anywhere else in the country. And it's happening right here. This is a picture that was I grabbed off of the news clip from last August. Every August here in this city we have a Overdose Awareness Day. It's called Scotty B Overdose Awareness Day. It is a day of sorrow and a day of hope. You know, we come together and we mourn those who we have lost in this community, and we also talk about ways that we can look ahead and be hopeful and hopefully find a solution to this crisis locally. But this is happening right here in Rochester. This all began with the Sackler family. Has anybody heard of the Sackler family? This is sort of hitting the news in a big way lately. I printed out some information about them because I have to admit I did not know very much about them until I read this book, and then did a little bit of research. So Mr. Raymond Sackler is a physician. I did not know that. He is a physician, a medical physician trained in psychiatry, practiced in New York City. His wife Beverly, together, their net worth is $13 billion, with a B, $13 billion. They are the owners of Purdue Pharma. Purdue Pharma is the manufacturer of OxyContin. And to make a long story short, they made money on this epidemic. And this is where it all began. This is the label, a picture of the label on OxyContin. And I'll read to you the one sentence that changed the world. Delayed absorption, as provided by OxyContin tablets, is believed to reduce the abuse liability of a drug. This was on the label. This is completely wrong. Inaccurate, untrue, not borne out by any scientific fact. And it was on the label of every bottle. It was marketed very heavily as not only not going to cause abuse, but potentially even protective against abuse. It's one thing that it was on the bottle. It's another thing that we all believed it. And when I say we, I mean we as physicians as well. This is the one article, if you want to call it that. It was a letter to the editor in the New England Journal of Medicine, very prominent journal. This is the only published piece that I was able to find that supported that finding on that label. And this isn't even an article. This is barely even a letter. But as you can see here, it says addiction is rare in patients treated with narcotics, and this was published in 1980. So 15 years before this entire thing. That's how far back Purdue Pharma had to go to find something that even resembled medical evidence in support of their claim. 15 years is a long time in medical history, and this simply underscores the fact that there is no medical evidence to support their claim. So they had a false claim supported by false evidence, and that predicament is what produced the OxyContin epidemic of today. And so as was mentioned earlier, we own this as physicians. We own the beginning of this crisis. We meaning the medical, establishment here in the United States. This was a brochure that I got when I was going through my orientation at Strong Memorial Hospital. I moved here from Chicago in 2009, and this was in my orientation packet. Right there, it says, the fifth vital sign, pain. I'd heard that phrase in, the late 1990s when I was in training. And it made me bristle, because there's nothing vital about pain. When you think of heart rate and respiratory rate and temperature and blood pressure, those are vital signs. When we're taught in medical school to assess a person's vital signs, we're assessing their vitality. Are they alive? There's nothing about pain that says anything about your vitality. And yet there you go. We called it a vital sign. It was called a vital sign because it was meant to be a universal screen, a universal assessment happening at every point a patient would interact with the healthcare system. And everything we do starts with vital signs in medicine. And so the theory was, well, if we talk to our patients and listen to our patients better, and the same is still true today, really, but if we did that better, they would be better off. And so pain became one of those topics that we wanted to center everybody's assessment around. And so we asked everybody, what was their pain score? Asked them to rate it on a scale of 1 to 10. That was a mistake too, because my 2 is different from your 2. It's different from your 3. And there's a whole lot of pain that we can't put a number on. Pain is in many ways a feeling. Can you put a number on your happiness? That's also very subjective. And so the fact is that this whole thing kept going. And as it was mentioned earlier, incentive programs came about, trying to provide incentives for healthcare providers, teams, hospitals, and so forth to do everything possible to reduce the pain score. Because on the face of it, everybody might agree that if your pain score was low, it would be better off. Is this thing working? And here I just blew up the area here. This was endorsed, revised by Strong Health Palliative Care in 2001, revised, adopted by Excellus Blue Cross Blue Shield locally. So this wasn't just a small project that a resident put together one day. This was endorsed by the major forces in healthcare at the time. And this is right here in Rochester. And so when all of this came into being, this was 1990, this is 2016, and this is essentially a depiction of the combined retail sales of all opioid products in the United States. And I want to call your attention here to orange, because that's OxyContin, all right? So this began in 1997. 2010 was the peak of OxyContin prescribing in the United States. 2010 really was the peak of opioid prescribing in the United States. And it increased so rapidly as a result of all of the internal pressures in the hospitals as well as all the external pressures on patients and consumers to do everything possible to reduce pain. And Macy goes through a long exposition on why and how that came to be in the United States. And frankly, it was a lot of people who were well-intended, well-meaning, but resting their entire thinking on false premises, including doctors and the industry and the public and consumers and patients. But all that to be said, 2010, we in the United States prescribed enough opioids to medicate every adult in the United States around the clock for a month. That was 2010. And if you think back to 2010, that was ancient history in the opioid crisis. And what Macy does an even better job of doing is articulating what happened between 2010 and now. Because what happened between 2010 and now, so 2010 is right here. What you're looking at here is the overall opioid-related death rate in the United States, broken out by the different types of opioids. So 2010 is right here. This is all opioid fatalities, barely even halfway to where we are today. And she talks about what happened in 2010, and in 2010, I remember this because I was here, we began to prescribe opioids less. We heeded the call that we were over-prescribing opioids, and by and large, we were successful in mobilizing ourselves to over-prescribe less. Unfortunately, the root of this problem is not opioids, it's addiction. And what we were doing inadvertently through all of these years of prescribing opioids was that we were sensitizing people with opioid addiction to opioids. And what they were doing is using prescription opioids to fuel their disease of addiction. And when you take away what it is that somebody is addicted to, and you haven't done anything to treat their addiction, well, then it's no surprise that they're going to switch from one thing to another thing, a substitute. So the substitute for OxyContin in 2010 was heroin. And as you can see, not surprisingly, heroin started to go up 2010. But if you think back to newspapers and news reports in 2010, you probably didn't hear about opioids or the opioid epidemic, certainly, in 2010, not anything like we're hearing about it today. Things really started to go off the rails when heroin became relatively more expensive. The economy around drugs and prescription drugs is described very, very completely in the book. But suffice it to say, as heroin became more expensive, more difficult to obtain, people started looking for cheaper and more potent alternatives. And that cheaper and more potent alternative is fentanyl. Fentanyl, as maybe somebody in this room knows, is a medication that we often prescribe either through an IV or through a patch. And it's a very potent opioid. We use it in the hospital. We use it for procedures, delivering babies, surgeries, and so forth. What people are finding on the streets is not that, typically. What they're finding are fentanyl relatives. We call them synthetic fentanyl analogs. So they're related to fentanyl. But for those of you with a chemistry background, maybe there's a methyl group that's rearranged, or it's some kind of a small little permutation, but basically it's still fentanyl. The challenge with that is that fentanyl is a controlled substance by the Drug Enforcement Agency. But it's very easily modified with chemistry. So if you take a fentanyl molecule and you make a little twist on it, that new compound is no longer a DEA-regulated controlled substance because it's not fentanyl. It's some relative of fentanyl. So all these other synthetic analogs of fentanyl can't be regulated because they have to go through the entire process, even though by every stretch of the imagination it's the same thing. And that is one of the pitfalls that Macy criticizes our establishment on, is the DEA and the FDA were essentially victims of otherwise smart, well-intended drug dealers. And so there you go. Fentanyl took off. So this is the fentanyl line right now, and this is sort of 2017 and counting. In Monroe County, we have released the first 6 months of data for 2018, and I'll show you those later. But 98% of the fatalities in Monroe County involved fentanyl. 98%. So it's basically all fentanyl. And that's why I've called it on WXXI not just an opioid epidemic, but a fentanyl epidemic. Okay, we've got to find a way to, first of all, cut off the supply of fentanyl, and then protect people who are at risk of using it. Because the reality is that most people who find themselves using fentanyl did not intend to use fentanyl. Because this is what fentanyl looks like. This is heroin. This is what a lethal amount of heroin would look like. And for scale, this vial is 2 inches tall. And this is a lethal dose of fentanyl. This is all it would take to kill anybody in this room. And so if you're a drug user, you can't even manipulate that. You can't do anything with that because it's just such a small quantity. What people are doing is taking, amounts of this and mixing it in to marijuana, to cocaine, to benzodiazepines, to other opioids, to meth, and we're seeing that more and more now. On average in Monroe County, when you look at the number of substances listed on a cause of death death certificate, the average number is 2.5. So on average, people are dying with 2.5 substances on board. So 2.5, somewhere between 2 and 3 on average. And 98% of the time, one of those is fentanyl. Most of the time, people don't know that they're using fentanyl, and by our investigations, we don't believe most of these people are intending to die. Most people are using these drugs simply as in the course of their disease without any kind of suicidal intent. So these are all, by and large, accidental fatalities. This is a graph that I like to show particularly in medical audiences, but I think it's important here because one of the criticisms, and trust me, I accept as a physician, I think we need to accept some of the blame in this crisis, but I think we need to evolve from that view because it's no longer just about the doctors and prescribing. And so what I've shown to you here is CDC data where I've taken every county in New York State, and in blue here, these blue bars are the per capita opioid overdose fatality rate. So you take big counties and small counties, you put them all on the same scale, and for example here, Richmond County has by far the highest opioid overdose fatality rate. Okay, so all the counties, big variation across the state. This orange line here is opioid prescribing. And I did the same kind of analysis. I looked at the total amount of opioids prescribed in a county divided by the total number, and essentially have a per capita opioid prescribing rate. And I put them on the same graph. And as you can see, there's really no correlation between opioid prescribing and fatality anymore. These are as of 2017. So the county here, which is Sullivan, which has by far the highest opioid prescribing rate, has a fatality rate that's somewhere in the middle. And then here on the far right, Kings County, the lowest opioid prescribing rate, has probably one of the higher opioid overdose rates. So there's basically no correlation anymore between opioid prescribing and fatality. There really never was, but it's no more true now than ever before. And my point here is to say that if all we do is beat up on hospitals and doctors to prescribe less, there are many in our group who think that the problem will get worse because we'll repeat 2010 all over again. We'll take away these opioids, people will go to the streets, and then they'll find their fentanyl, and then they'll die. So we've got to be very careful in this messaging, and this is something that Macy points out in her book. Again, these kinds of messages are almost too nuanced for the typical audience on TV or even in the newspaper to comprehend. And as I mentioned before, these are the opioid numbers, total numbers of fatalities here in Monroe County. 2011 was the first year we kept track, and we had 8 in Monroe County. And 2010 was the peak of opioid prescribing, and it only got worse from there. Went up steadily. 2014 went to 81. It went down in 15, and we were kind of hopeful. Turns out that corresponds to the availability of heroin in this county. It kind of peaked and then went down, and then this huge surge in 16 is the representation of what fentanyl did in Monroe County. And so before you get too excited, 2018 here, the number 99 refers only to the first 6 months. So, who knows what the rest of 18 will show. We ought to know that probably later this summer. But all things being said, the impact of this crisis is unprecedented in the United States. We're looking at life expectancy here in the United States. Life expectancy is the number of years you're predicted to live as of your birthday, the day of your birth. And it's gone down 3 years in a row in the United States. 3 years in a row and counting. The last time it went down 3 years in a row at all was in World War I. And that was a very different time. It went down 2 years in a row shortly after World War II. And the last time it went down at all is actually here on this graph, 1993, HIV and AIDS. And by every stretch, the opioid epidemic has dwarfed HIV and AIDS in just about every number you can think of. And so all of you were here during the HIV and AIDS epidemic, all of the attention well intended that deserved, and that is nothing compared to what we're dealing with today. So for those of you who are still yet not believers, I want you to imprint this picture in your mind. This picture is intended to demonstrate that addiction is a disease. It's a disease of the brain. And what I'm showing to you here are PET scans of the human brain. PET scan tells us about the metabolic activity and energy consumption and so forth. But suffice it to say that this is a normal brain with the normal yellow pattern here. Normal meaning somebody who's not using drugs in this case. And this middle picture is the picture of somebody who's got an addiction to cocaine. Very different picture. Brain activity is very different. And it turns out that this middle picture is a picture of somebody who hasn't used cocaine for 10 days. So that cocaine has left that person's bloodstream. That person's physiology is no longer responding to cocaine because cocaine is eliminated from the body within days. And it's still having an impact on this person because this person's brain is still different. This is proof that addiction is a disease of the brain. Even though you've taken away that opioid, that person is still very sick. The last picture is the same individual as in the middle picture after 90 more days. Person's still sick. And we know this clinically because a lot of relapses happen in addiction. It's a chronic medical illness, so very analogous to heart failure or asthma, where you can have a relapse, we call that an exacerbation, and you end up in the hospital. That's just the reality of a chronic illness. It's not any indication of the individual. They may be taking their medications, they may be following their diet, and sometimes we see flare-ups of chronic illness just because of the nature of the chronic illness. Same thing is true with addiction. People have a flare-up or a relapse, we call it, of addiction, and they may end up with an overdose or in the hospital. So addiction's a disease. It's a disease of the brain. And because it is a disease of the brain, unlike a lot of other diseases, diseases of the brain impact our ability to think clearly because it's a disease of the brain. And so this notion of choice, and Macy goes into this a little bit, the notion of choice is a little different when you're talking about somebody with addiction. It's complicated. You know, people who are struggling through addiction often tell me, I didn't choose to become addicted. You know, talking about really underscoring the power of this disease, really taking over one's ability to have an autonomous ability to choose. And yet they'll also say, I'm in recovery because one day I chose to get better. So this notion of choice, this notion of autonomy is complicated. And I don't think we fully yet understand that sort of role of choice and autonomy in a disease of the brain. But I think we would be well served as a community very simply not judging these people. You know, we don't judge people with cancer. We shouldn't be judging people with diabetes, and I think we shouldn't be judging people who struggle through addiction by the same token. And it turns out that addiction is no more common now than it was 15 years ago. So what I'm showing to you here are, you know, the prevalences of various addictive disorders, and I won't go into all of them except as to say alcohol is by far still the most common. But when you look at all these drugs, the overall prevalence of addiction to each of these different things has been largely unchanged. And this goes up to 2014. So this doesn't look anything at all like the opioid overdose statistics I showed to you earlier. Because addiction is not, it's the root cause of the problem, but it's not the problem that we're learning about and hearing about in today's news. So when I approach the opioid crisis as the Commissioner of Health, I know that we've got to look at addiction and we've got to look at the overdose epidemic as separate but related problems. So if we can take care of addiction, and we'll talk about that, if we fix addiction, we're still going to have an overdose problem because we're still going to have fentanyl and we're still going to have all the risk factors that people possess before they overdose to fentanyl or what have you. The risk factors for both are different. By the same token, if all we do is, you know, distribute Narcan and help people to not die, that's not going to fix the addiction problem because it's a different problem. So it's a very complicated situation. So Macy goes through probably the latter third of the book, underscoring the importance of medication-assisted treatment. And this is complicated because, you know, forces us to change how we think of treatment. First of all, these are medications. These are drugs that are prescribed, but they're also, in some instances, opioids. Methadone is an opioid. Suboxone is also a type of opioid. And the scientific evidence says that we have to prescribe these. These are the best way to treat somebody's opioid addiction. And so there are people who still believe that abstinence only is the ideal form of treatment for opioid addiction, and that's problematic because we know that people who pursue abstinence-only approaches have a higher rate of death. It doesn't actually work. The best approach to treating addiction is through medications like this that are safer than the heroin or fentanyl that you might find on the street. But this is a difficult part, and this is controversial to some degree. It's certainly complicated, and I think it's an area where I think when we look at the crisis here in Monroe County today, this is the question that we have to resolve, the one that we have to think about, have a conversation about, and come to some agreement about. But the medical community is clear that medication-assisted treatment is the way to go for addiction. There are a whole host of barriers in the system, and Macy talks a lot about this too. In order for somebody to prescribe any of those medications in this country, you have to go through an 8-hour training. And there's a limitation to the number of patients that you can prescribe Suboxone to. That's unprecedented. I didn't have to go through 8 hours of training in medical school to use insulin, and there's no limit to the number of people I can prescribe insulin to who have diabetes. So why do we have the same requirement for Suboxone? It's an example of that stigma that exists within the FDA. And that's an area that Macy also criticizes, and I agree with her. So at the end of the day, let me skip ahead to a couple of things because I think we're trying to sandwich in here between one. The Monroe County Action Plan, Opioid Action Plan, was released by our County Executive Cheryl Denolfo just over a year ago. And I still believe that this is the best example of collaboration that I can think of in this community around a multifaceted, complicated health problem. It's not just a health problem, it's a criminal justice problem, it's also a law enforcement problem. But the reality is that, we're working on this on multiple fronts. I'm working within my profession, within the ERs and primary care offices, really trying to do everything we can to reduce the stigma. We're trying to coordinate information so we can describe the extent of this epidemic. And we're doing education as much as we can to talk about Narcan and how to reduce and prevent mortality from this epidemic. We have a website, monroecounty.gov/opioids. I encourage you to take a look at it. There you'll find some posters, some materials that we're trying to release across the community to promote awareness around this topic. We've got posters available. We've sent them to every restaurant in the county where we issue restaurant permits, educating people about what Narcan is and where you can find it. Very analogous to the choking posters you may be familiar with. Video online, if you want to learn how to use Narcan, you can do that for free. And we have classes at the health department. So bottom line, thank you for being here. I want you to do everything you can to raise your awareness about this epidemic. If you know of anybody or if you're struggling through addiction yourself, please get help. The last thing we want to see are these statistics getting worse. And with that, I'll take questions.